Hello, everybody. This is Dave with the RFS. Thanks for hopping in tonight. We're very excited to have Dr. Chopra speak on peripheral arterial disease practice management. As always, if you want to get more involved with the RFS or have suggestions for webinars or clinical events, just go to our webpage, rfs.sirweb.org. I'm going to introduce Amit Baku. He's been a stellar RFS member who's done a lot of these practice building talks. A lot of them have been successful because of him. He helped set this up. So Amit, the stage is yours to introduce our speaker.
Thanks, Dave. Thank you for joining us tonight. I'm very happy to introduce our speaker this evening, Dr. Romi Chopra. Dr. Chopra joins us as the founder and medical director of the Midwest Institute for Minimally Invasive Therapies in Chicago. He completed his medical education in India, after which he completed his residency and fellowship at Brigham and Women's Hospital in Boston, Massachusetts. Eventually found his way over into the Midwest and served as a division lead of IR, eventually becoming chairman of the Rush University Department of Radiology. And Dr. Chopra eventually left the chairmanship of Rush to form the Midwest Institute of Minimally Invasive Therapies while still remaining a Rush professor. And we're very fortunate to have his presentation this evening. And just for those of you who won't be able to make it to the Learn meeting, this is a version of the talk you'll be given later this week at the meeting. And again, Dr. Chopra, thank you again for joining us.
Thank you. Thanks very much for the introduction. What I'd like to do tonight is really give you a feeling for a completely new paradigm of how interventional radiology is being practiced today, how it was in the past, and where we are today. As you mentioned, I was in academics for a very long time, but I also grew up in a business family and was surrounded by business, and I soon realized that the business of healthcare was in total mess. And as I saw changes, I realized that the landscape would be changing and started to change the business model that I was working in. Though my talk is titled Building a Peripheral Arterial Disease Management Practice, it can be applied to any service line. And what I will do today is talk to you a little bit about the kind of paradigm and the strategies of how to go about building a practice. And truly, it's a small business, and we'll go from there. Now, you could be in a large academic practice, you could be in a large private practice, you could be in a multi-specialty system, could be a single guy. The principles are still the same. So let me go from there. My goal today is to give you kind of this framework that can help you for a lifetime of clinical practice. We'll talk specifically about peripheral arterial disease. I will not be talking about procedures and techniques, but I'll give you my views on why a clinical office-based IR practice is important versus a traditional radiology business. And one point here to say is, when you talk to any other doctor, they don't talk like, oh, we need to be clinicians. We all are clinicians, which is a very important thing to remember. Unfortunately, when we are in radiology, diagnostic radiology, we forget that for a while. I'll discuss the pros and cons of the practice model and then give you a leadership and management perspective kind of from the top. I'm sure everybody's seen Star Wars, and when you're a resident and you're training, you're like an apprentice learning to be a master Jedi. I've trained many fellows and residents, and it's harder than you think in some ways, but it's also a great feeling, but it sets the foundation for your future. And then when you're ready, I mean, I use this paradigm also because we are in a war against disease all the time. What you don't realize is you're fighting some of the forces that want to end human life. In this case, let's talk about PAD. But let's talk a little bit about business. What is business? It's about meeting your customers' needs, and you're actually exchanging value. What is of value to you depends on you. It could be just pure money. It could be this feeling good about something. That's why people do charity. Some do recognition. And business also is about managing risk. You want the maximum gain for the minimum use or loss of resources. When you look at healthcare business, it's a multi-trillion-dollar business. But the mission of all mankind is really of any culture, anybody, anywhere, is to preserve human life and make it better. And in medicine, we are in the business of taking care of other people. Now, when you look at traditional medicine and surgery, it's about maintaining health, diagnosing disorders of the human body. Radiology, when the Röntgen ray was discovered, it was, oh, we can look into the body now. And soon, imaging became sophisticated enough that you could look inside the body. And then came interventional radiology, where you could use image guidance to start treating problems. Now, as medical imaging became really complicated, really sophisticated, it needed folks who had those skill sets. But when IR grew out of that, we got trapped in a paradigm that we didn't want to be trapped. And when you look at the radiology business paradigm, and some of you folks are probably, those who are medical students are going into radiology departments, those who are residents have already been through radiology. So radiologists look at films. I'm a radiologist too, and there was a time all I did was look at films and look at images. I get paid for, and I got my value by interpreting images and reporting. But I never touched a patient at that time. And at that time, there's no direct patient contact. Initially, it used to be, a lot of it was hospital-based. Now it's majority is teleradiology. So you're staring at a computer screen. You could be there for 10 hours. As a business, you have outpatient centers, inpatient centers. It's very capital expensive. And a lot of radiologists don't like to touch flesh or another human being. A lot of them have a 9-to-5 mentality. A lot of them are risk averse. I don't want to touch another patient. I don't want to stick a needle in somebody. Why should I get exposed to HIV, hepatitis? And the money was really good. That has changed, of course, and it's still changing. And traditional surgery was all about, solving problems, but with direct patient contact. Think about the time when you are not well. You go to another human being, and you want him to solve your problem. Now, surgery had higher risk. You could kill somebody. But at the same time, there was the option was to, or rather the end result was you want to solve a problem. But with time, because the risk of surgery was so high, that we started looking for less invasive options. And this happens in all aspects of life, not just in medicine. You look at cars, every year we make it safer. You look at food, you look at imaging, you look at everything we do, we want it to be faster, better, or cheaper. And as the option to look into the body and do kind of precise strikes at whatever disease process you were looking at, which interventional radiology grew out of that. And interventional radiology became like special ops. Earlier they used to do carpet bombing of entire cities, which is like radiation all over the place, a lot of collateral damage, versus now you have very specific strikes without much collateral damage. We do that war on disease, whether it's in interventional oncology. In this case today we are talking about PAD. So with minimally invasive therapies, we're looking at improved outcomes with less risk. Because we were good at imaging, it fell into our laps as radiologists. And then folks came into it who the only pathway was through diagnostic radiology, that folks started to realize that, geez, I need to be a doctor too. I went through a pathway that took me away from clinical care. So that paradigm started to crash. Folks who had to do this, for example, myself, I was told by a surgeon many years ago, even when I was the chairman of a radiology department, that I couldn't touch a patient and I couldn't see a patient. And that's one of the reasons why I left the chairmanship and actually started my own institute and started doing it. So, and IRs were always seen as innovators. Some of them were just mere mavericks, but we clashed within the radiology department. But many years ago, a few years ago, money was abundant, salaries were huge, so it didn't matter. The problem got solved. But now the healthcare business environment has changed. Healthcare reimbursement, everybody knows about Obamacare. With all the different aspects coming, it's all about economics. It's all about managing the amount of reimbursements and the cost of healthcare. At the same time, as I don't know the name of the professor, but a Harvard economist said, when the bananas get short, the monkeys get restless. And as this happened, with increasing competition, reimbursements started to go down. At the same time, technologies were exploding, procedures were becoming more complex. Diagnostic radiology groups didn't want to invest in this, and IR started growing, and then at some time, interventional radiology started blooming out of a paradigm where today it's its own specialty with its own residency. When I was doing this 10, 15 years ago, it was impossible. but there are some folks in some places where they're still within the diagnostic paradigm. So as you're training today and you're coming out and you want to do this well, then you can get into a paradigm where you're actually a clinician taking care of patients, which we'll talk about. Now, there was a time when the interventional radiologists judged procedures, as in some places still do that. But it was like going to play golf as everybody else teed the ball for you and cleaned the ball for you, and you just hit the shot and walked on to the next thing. Primary care docs, the other specialties would take care of the patient. The interventional radiologist would just do the procedure and walk away. There was no longitudinal follow-up. There was no wondering about how the patient's feeling or what was happening. Soon the other specialists figured this out and started to learn image guidance and said, I'll take care of the patient. That's when all this started changing. At the same time, and there's some places where this still happens, where large radiology groups still have imaging contracts with the hospital that allows them or are required to have a interventional radiology as part of it. But most places, that has started to change, where the high reimbursement procedures are done by the vascular surgeons and the cardiologists, and a lot of IRs were just left with PICC lines and simple biopsies. This then started to change the paradigm, and a new model emerged. Let's treat the patient. Let's be real doctors. Let's solve a problem. I call my practice the mother practice. Means I don't do anything that I won't do in my own mother. We've got over 10,000 patients in my practice. We have the whole, it's like any doctor's office. I have patients, like just today, I had a patient that was actually doing a venous procedure on, said, Doc, I trust you. I had pancreatitis before. I'm getting some abdominal pain. Will you be my primary care doc and order all these labs for me and take care of me? Now, that's a huge compliment to get from another human being, especially knowing that I'm a radiologist. I have many, many patients who want me to be their primary care doc. And I have a patient who actually is a medical device executive and lives in Texas. I'm in Chicago. But when he comes here, he wants me to see him. And even though he doesn't have a radiology problem or a vascular problem, I'm now become his regular doc. That's the kind of thing that you want to get to, and you can have a choice. So in this new model, where you're taking care of patients, it's a huge satisfaction for yourself. You're saving lives. You're a real doctor. People really care for you. You really care for people. Financially, it's very rewarding. You have control over your own practice. When I'm doing a procedure, I don't call anybody and say, can I do an angioplasty? Can I put a stent in? Can I do this? No, I'm the doctor. I take care of that patient. That patient's mine. I'm responsible for the patient. But you have to be able to get to that point where you can handle your own. Now, as a specialty, when we all do this well, this specialty will survive as well. If you're going to be within a diagnostic radiology group and be an IR, it's advantages for the radiology group because, and I've had both, diagnostic, IR, I've had a combination of both. I've had surgeons that I've hired, primary care doctors that I've hired. One of the things that happens is the hospital's respect for radiology groups starts to grow immensely when they see that you're really patient-based. There is no other option than to have a proper clinical practice and be office-based. If you're going to do PAD, you're going to do cancer, you're going to do anything else. We cannot just be technicians sticking things into people or like we're dealing with a car. So when you have an office-based practice, you have closer ties to patients. You start bonding with them. This is less risk, less lawsuits. In 30 years of practice, God bless, I've had only one lawsuit, and that was for a patient I never saw. And that too got settled out. By which I mean is when you are closely attached to your patients, they forgive you if you make a mistake. Then revenue-wise, you bill for evaluation and management services. You control patient referrals. I refer patients to primary care docs, other specialists, and a whole variety of people just as any other physician would. At the same time, hospitals respect IRs when they are real doctors. And I'll give you my personal example. I'm in 3 hospital systems, all 3 of which have large diagnostic and interventional radiology practices of their own. And I am still an independent there, and I sometimes do more volume than the group that's part of the hospital. The reason for that is you do high quality work. Some of the challenges are you need more business sense, you need to invest, you need office space, you need staff, you need medical records. You have to deal with all the patient care issues that pop up with it, but that's what being a real doctor about. Now, you could be your own private practice, you could be part of a multi-specialty group, but still, no matter how you do it, you will still be your own unit and you have to be responsible for all of this. So my institute is called the Midwest Institute for Minimally Invasive Therapies. There are always some changes going on. At one point we had 6 hospitals. We were consolidating. We had 3 multiple IRs. We had a vascular surgeon. 2 of them we've had some transition now because 2 of them retired. We have nurse practitioners, PAs. We even had primary MDs in our group. We get referrals from internists, cardiologists, vascular surgeons, podiatrists. My biggest referrals are from other patients. Just today, I took care of a lady for UFE. She was referred to me by her husband, who I did venous procedures on, who was referred to me by his mother, who I did arterial work on. 30+% of my patients come referred by other patients. And the approach is very simple. It's win-win or no deal. If I can do good for the patient, I send them to somebody else and vice versa. We do some very complex arterial work. We do pedal sticks. I routinely do DP, posterior tibial, anterior tibial, perineal punctures. We work with wound care centers to do amputation prevention, podiatrists, etc. We admit patients to the hospital. There's a practice in each hospital. We share cath labs. We have privileges in the operating room. We admit, we follow up patients. Very active office practice. We do office-based procedures, all the things that are required. So it's just normal to have treatment rooms, office equipment. We have our own vascular lab, so we can monitor patients, do all the non-invasive imaging that's required, and do best of practice. So for this part, the bottom line is that if you are just a diagnostic radiologist and hope to do some IR part-time, that's going to be a problem for you. But if you want to do this well, I give the example of, you want to be a Marine or a Navy SEAL and you're stuck in a local small police department and you're directing traffic. You're bound to be frustrated. So you got to choose where you want to go. And I have a lot of people who tell me, my radiology group doesn't want to do this and that. And I ask them only one question. I said, did anybody force you to join that practice? No. So I think you have the choice as we start to do this. And the only way to do this is to do things faster, better, and cheaper. That's the way it is. So as a joke, it's you got to set your eyes. You got to watch what you set your eyes on. Sometimes if you're on the wrong thing, you can get yourself killed. And sometimes you get others killed. By which I mean you want to do the right thing and make sure you create a good brand for your practice and yourself where it's high value. And you will know you've succeeded when other doctors want to be your patient, or other doctors will send you their loved ones, whether it's their wife, their child, and they know that you have very high ethical standards and you'll work hard. So with that paradigm, how do you develop a thriving, in this case I'm talking about PAD management, but this could apply to any aspect of whatever. I do a cosmetic line, we do spine work, venous work, fibroid embolizations. So, you look at it and you say, how do I do this? So I'm going to give you some practical tips and pointers. So first is that, you're in the service industry. And they say that any business requires 4 pillars at the least. And you can think about this, whether it's a car business, a hotel, any business. First is excellent quality. Second is you want excellent customer satisfaction. Your customers need to be happy. Your patients need to be happy and satisfied. Your employee satisfaction. Your employees need to be satisfied. Fourth is fiscal responsibility. If in any business you're not making a profit, you may be a church, but if you're not making money, you can't survive. That's the way life works. And to that, you add innovation, where you're constantly innovating. And finally, sustenance, which means that you can sustain the other 5 things. You will never go out of business. You will thrive and do very well. In a PAD business, you got to realize you're dealing with a problem called atherosclerosis and related conditions. Like all businesses, you want to have an exchange of value, which means you're going to solve the patient's problem, make them feel better, prolong their lives, and make sure the quality of their life is good. So you start thinking about, why am I doing this? What makes me happy? That's the first thing that's important. If you're happy just sitting in a room reading films all day, you don't want to be an interventional radiologist. But if you, on the other hand, want to be passionate about saving limbs and you have the skill set to do this, then you want to do that. There are other things that will focus on what you want to do. People have key life interests. This is from study. This is published in Harvard Business Review. Where you look at it, where most people have a combination of these 2 or 3 of these 7 attributes. One is enterprise control. These people become CEOs. Others want to mentor and relation building. They become teachers and they become coaches. Third is managing people. They are team builders. They become coaches in sports world. Creative production, artists. Others who are exchange of ideas through teaching and academics. Most academicians, this is the dominant trait. Some see numbers even in their sleep. They become accountants, finance people, and there are others who like to tinkle with stuff. They're engineers. And you'll find that you've got 2 or 3 of these, and one of these is dominant, and you figure out what makes you happy, what takes you there. So when you look at, say, I want to do a PAD practice, you start by saying, what do I want? Begin with the end in mind. Why am I in medical practice? If you are the kind of person who feels very good about taking care of people and you're not worried about money, then you'll go into a charitable institution. But one of the things that's happening with PAD today is the market is huge. Our population's aging. Everybody wants to live as long as they can. At the same time, want to make sure that they are moving. I have 90-year-olds who are driving, active, doing all the things. So there's a huge unmet need. It is estimated that there are 12 million people today with PAD and only 2 million are identified and treated. The other thing is it's very challenging. Diabetes is a pandemic. Smoking is still a problem. You combine the two, and PAD is continuing to increase, and not just in the U.S., it's actually globally. And it is not easy to treat when you start working, especially with infrapopliteal disease. There's always room at the top. If you are doing well and you manage this better, you will make good money and it'll pay well. Just to throw in, there's a small, this is a small business model described by a guy called Michael Berger, and he described the E-Myth business model. E-Myth stands for the entrepreneur myth. You can go to his website. He talks about the 7 centers of management excellence. For any business, any enterprise, including healthcare, including a PAD practice, the first thing is you need leadership. Leadership is about vision. Where am I going? Why am I doing this? So if you decide, I'm in Chicago, and say, you know what, I want to go to Boston. Why am I going? How? Management is about how to get there. So if any business, the first is leadership. Then you want to know your market. Where are these patients? You're going to need money. Money is the blood of any business, the blood supply. Then you need to manage all these resources. You need to generate leads. These people in these markets need to get to know that you are the PAD expert. You need to go out and find them. Are you going to put up a billboard? Are you going to talk to other doctors? Are you going to tweet about this? How are you going? What are you going to use social media? Once they come to you, they call your office. They call you. You have to convert them from just a mere lead into your customer, where you are solving their problem. Now you've exchanged value with them. When they keep coming back to you, they are now your client, and you want to take your client. So in this, your leadership is, what's your primary objective? I want to be the best PAD guy around. I want to make a lot of money. Whatever your objectives are. You will then need resources to manage this, which is money. You may work for somebody. You may work in a large system. You may invest your own. There are a lot of office-based labs being opened right now. Marketing is about finding out who your customers are. And Starbucks is fantastic at this. Starbucks will never open a Starbucks store or a coffee shop, cafe, where those folks cannot afford a $4 and $5 cup of latte or cappuccino. Management is about managing the processes and the systems. How do I develop the business? What's going on? And if you are going to actually start something of your own, you need to be a manager as well. Lead generation, as I said, is how do I get more people interested in coming to me? Once they come to me, how do I make them my customer? Once they are your customer, what do I do for them that solves their problems and makes them very happy that they keep coming back to me? They are now your clients. And in any business, you're going to have three roles as a PAD specialist. One is the technician or taking care of that, doing that procedure, providing the service. Second is the manager. You have to manage the records, the information, all the other things that go into making sure that all of this works well. And finally, if you're an entrepreneur, you have to risk money and be an investor. And these are three specific different roles. Either you can do this all yourself, or you can have other people work with you as a team. Most folks I've seen over 3 decades of doing this are excellent physicians, but they fail in the other two aspects of being a manager and an entrepreneur and land up in a crisis. Businesses also go through a cycle. You have to constantly be innovating. So every day I'm looking for what's the next best thing I can do for my patient. But I have to at the same time make sure I'm fiscally responsible and I'm not wasting money. You can't measure what you can't fix. Let me put it the other way around. You can't fix what you can't measure. So you have to actually be able, how can you treat a patient's fever if you don't know what the temperature is? How will you treat somebody's blood pressure if you can't measure it? So quantification in any business becomes very important. And there are multiple systems that will work within the practice that have to be put together. So when you come into looking at PAD, you will start to say, for example, we are now doing pedal access. I'm routinely doing radial artery, transradial access, and radial artery approach for solving problems. I'm getting the patient up faster. I'm doing the procedure with less complications, and I'm doing it cheaper. I'm measuring the outcomes of all these patients. I have satisfaction surveys. Once we hear there's a problem, once we measure the problem, we then go out and orchestrate and improve the system around how that has to be solved. And in any business of any kind, there are two strategies. One is people, because everything is designed to meet human need. And as you do this, you will be one of the people in an persons in an organization. And the second is to have systems where you will make sure that the right systems are in place. Now let's talk a little bit about some of the office-based labs out there. Feel free if you have any questions to interrupt me at this point, but I'll continue till then. So one of the first things is the office-based lab. And one of the things that's happening right now is a lot of physicians are opening office-based labs. These office-based laboratories are really where we are in an office setting, got a full cath lab. We're doing procedures in there. And the reason for this is that it's a small business. Doctors were not making enough money, and have decided I want to be an interventional radiologist. I want to take care of my patients, but I'm getting paid very little money, and therefore, and I want the independence, and they're starting to do the procedure in their own office setting. So it's really a small business, and we invest in the technical component of all aspects of this. The X-ray zone, X-ray equipment, the staff, the operations is definitely higher risk, but there's also higher reward. But not just financially, but the independence, the satisfaction of doing things well, and everything else that goes with it. And there are different practice models that come with that as well. The office space can be entirely your own, or you could be partnering with a hospital or an ambulatory center. There, when you start partnering, the risk is a little lower, but there are also lower rewards. In this case, you're getting only the professional component of the income, and it's definitely is easier. Any questions at this point? Amit? All right, I'll continue.
There have not been any
So
questions asked,
as you
typed
start,
in. I have a couple, but I'm saving them for the end, just based off. So I think for now, I think we'll just keep going.
You can ask now. Not a bad idea. Why don't you ask it now?
Well, or if any do any of the attendees have a question, by all means, feel free to type it in or raise your hand.
All right. While that happens, let me continue a little bit here then. So if you decide you're going to do this and get into the PAD and actually build a PAD practice, you want to have a business plan. And most people think a business plan is a very sophisticated document. You got to fill all this fancy stuff. No, it's simply, what am I going to do? And start writing it down and start thinking about all the big stuff first, all the big steps, then start putting the small steps together. And
so
in any project you want to.
Dr. Chopra, Alok Bhatt is asking, how do I get capital to start a new practice, and how much do I need?
It all depends on what you want to do, and that's where you have to have a business plan. Let me ask you this. If you decide you're going to build a skyscraper versus buy a small condo, how much money do you think you need? Depends on where you're going to open it, depends on what you want to do with it, and what your objectives are. Now, where will you get money from? You can have your own money. You can borrow the money from somebody, family, friends, or you can go to a bank. You can get some partners. So they are, depending on your objectives and how much you're looking, many different sources of funding. So I'll tell you what I did. When I started, I believed in organic growth. So I knew I wasn't going to take some crazy risk. I started my own practice. I started solo. When I was solo, first thing I did was I invested my own money, because I knew the minute I took money from somebody else, I would have to answer to them and they would want a piece of the pie. I started figuring out what I needed to do, but I was in completely new territory. No radiologist had ever done this, what I was doing before. Once I got started, once I had some traction, I borrowed money from a bank, but I calculated my risk. And then I worked my way up from them, and I kept funding my own growth. So there are many different ways to do that, but you have to assess the risk, and you assess the benefits of what it is and how you work from there. I hope that answered your question. And that's where you see it says, where will I get the money to invest in the practice? You need office equipment, staff. Remember one thing, expenses start even before you open your door. Revenue comes 30 to 90 days after you open your door. And one of the key things about entrepreneurship and doing something like this is understanding risk and say, what's my appetite of how much can I lose, and then think of it and go from there. Did I answer your question there?
I don't think the Dr. Chopra, sorry, this is I don't think the attendees can actually yeah, I'll locate the back saying absolutely. Dr. Chopra, I do have a follow-up question for you though. In terms of the practice expenses before before you even open your doors, obviously technology's changed a lot from when you initially had started your private practice. And do you think there's a role for like online patient scheduling and kind of cutting out, some of the human capital in terms of like office staff or whatever, embracing technology, as some primary care or concierge practices do with having a website and a patient portal? You go to the website, you get an user name and ID, and then you schedule your own appointments and follow up on lab results and all of that through there. Do you think that would be something that IRs could embrace going forward, initially starting out when they can't necessarily put in all the money for a secretary or medical assistant and all of that?
Yeah, again, if you, for example, if you start and you're solo and you're going to do 3 cases a day, you can manage that. Now, as you grow, you're going to need a faster and better solution. And believe it or not, when you sign up, you will start paying for it right there. That's what I mean. Now, do you realize it takes about 6 months to credential with all the insurance companies? So I hired a doc 6 months ago. He's still not credentialed with all the insurance companies. And so there's a lot of complexity to it. So it seems very simple on the outside. It's not like going to a restaurant that when your customer leaves, he writes you a check right there or puts his credit card. It'd be great if that was the only way we got paid. But we have insurance companies and regulations to deal with. So yes, your cost will be less than when you started 10 years ago, but that's still a cost. There are a lot of solutions. They're cloud-based. Yes, there are a lot of those things, but still you have to look up your cost before and then work in there. You don't have to go out and buy servers anymore. It's all on the cloud, whether it's Amazon or anywhere else. But the cost still exists.
Got it.
And, great. Now, one of the first things you can do is understand your market. Where are my patients? So if you are in a community, you open your PAD practice in downtown Chicago, where all the healthy young guys live, how many PAD patients do you think you'll get? Very little. But you got to go where all the older people are and where there's this pathology exists. So you need to know your market. Then you need to say, how am I going to get these people to know where I am? That's some people call the marketing, but I call that generating leads. You may be advertising, you start blogging, you may use social media, and then you may talk to other doctors who see these patients. So you start looking up how you want to do this. Let's assume for a moment you're actually going to start your own practice as an entrepreneur. First, you need to get an entity going. You'll set up a corporation, then you'll share an office. Now it's easy. In fact, one of the models we have is if I go into a new community, I don't go and lease a space right away. I sublease a space from another existing doctor and tap into it. And there are places where you can get 1 day a week or something like that, and then you get yourself rolling and you keep your costs down. But no matter what business you do, whether you're in a restaurant and in a practice or anything else, you'll have a front office where people will come, patients will come, they'll interact. There'll be the middle where you do the clinical operations, whether you just see them in a clinic, whether you do procedures in the office or you do a procedure in a hospital. And then there'll be all the back office, all the paperwork, all the regulatory work, the billing, the coding, and then after that collecting the money. Then you got to do the accounting. You've got to file taxes. There's a lot of stuff that has to be done back office. There's a lot of help available. It's not, you don't have to figure out everything yourself, but these are things you'll need to think about. And when you look at an ideal PAD practice, what is it that I'm looking at? And it'll be hard for you to do only PAD because there just isn't enough, but you'll have to be really good and you'll have to really have a high volume, but you'll mix it up with other types of interventional radiology work. But let's assume for a moment you're going to do 70 to 80% PAD. First is you got to be really good at it. It's like you're the chef, you open a restaurant, if your food is good, a lot of people are going to show up. You want it to be in a good location that's accessible, or you will go to people. You want to offer a full range of treatment options in your practice. So you can't say, you know what, I only do angioplasties, I don't do stents. Or, you know what, I'm not going to do A or B and I'm going to send you to somebody else. After a while, patients don't like that, especially if you don't have good outcomes. And it's got to be a major focus of your practice. It can't be something you just do casually here and there and patients will not come. You want to offer your full ancillary services on site, such as patient comes in, they need ABIs, they need diagnostic testing, you should be able to do it. You should be able to give them all the information, educate them. And if you're going to do the procedures in your own office, in addition to your skills, you're going to need the equipment. You're going to need diagnostic equipment. You're going to need, somebody has a code. You're going to have all that equipment. You'll need charts, EMR, documentation. You'll have to get all the meds in place. You need the nurse. You need the tech, everything else that goes on. You got to track everything that you're doing because you've got to measure all of this. You've got to code it, bill it, collect the money, and track your dollars. You got to have a high level of customer service. I'm sure every one of you have gotten on a plane before. Has any one of you ever questioned the competency of the pilot and asked to see his flying license and times and certification? I can guarantee you never. But when you get off the plane and they weren't nice to you, it was too warm, you'll remember that. It is a human condition where we judge quality based on our customer service experience, how we feel at that time. And what then happens is if a patient, you may save somebody's life, but if they don't feel good about you, they walk away with a bad taste in their mouth and they don't come back or they tell 10 people. If somebody's happy with your service, most times, and it happens in all surveys, most people don't say anything. If they're unhappy, they tell everybody about it. So customer service becomes very important, and what you tell your patient should be no different from what your PA, your nurse, your front desk person, everybody. So in your business, there has to be the same body language, the same attitude of kindness, of caring, of solving their problem, and getting that going along. And it all starts from the day that somebody answers your phone and represents you. Once you've set up, the next thing is you're going to want to get patients coming in. Just as you've opened a restaurant, now you need people to know. I mean, for cosmetic stuff, we even do Groupons. I tweet about stuff. We blog. We do all those things that will connect with people, word of mouth. Social media is becoming fairly good at this, and I have patients who are on Facebook and will like my Facebook site and put pictures about how their legs look now. And soon as you start doing this, you will want to say, how do I treat more patients to meet my goal? You want to maximize the number of patients coming into your practice, And you want to minimize the number of patients leaving your practice, which means you got to know if somebody's unhappy. And you want to tell them that if you are happy, tell 10 other people. If you're unhappy, please tell me first. And then once you know, you'll figure out a way of how to get more leads, how you get the patients into the practice. A lot of people focus just on getting new patients, but don't focus on the existing patients. And existing patients actually are a great existing resource, and the cost of increasing your practice is much less than if you go out and put billboards and ads. In today's days, you absolutely need to have a good website. And in our field, vendors will support you a lot. You got to make sure you're ethical and within the law, but that's something else. But one of the great sources of referrals is other physicians, especially family practice. For example, PAD patients, diabetics have neuropathy, they get wounds, and they are not even sure that they have a problem. They go to a podiatrist. The podiatrist sees them and goes, I think you have a vascular problem, and then he sends the patient to a vascular person. That person should be you. And so you need to go talk to the podiatrist and make sure the podiatrist knows what you can do. When they send you a patient, you do a great job, the patient goes back. Now he says, I love this guy. He's going to send you more and more patients. The same with any other specialist, wound care physicians, et cetera, that goes along there. So that's another way that you kind of get that in. But once the patient comes to you, you've got to convert them. They got to trust you. Once you've taken good care of them and you've kept them happy, it's called client fulfillment. So you need a very high conversion rate. If you can, measure that, that's great. But if you're not measuring it, at least have an idea that of the phone calls that come in asking for a consult, and when you see the patient, how many of them believe what you're going to do and will come through for the procedure and then stay with you? I mean, I have patients I've followed for 12 and 13 years since the day I moved into Chicago. And you want your front desk all the way through to the person who calls for billing and collections to be on the same page with you. You want great service. You want to make sure you have a recall program where you actually call patients back. And when patients come to your office, they must feel the organization. And if you do marketing, which I'm sure you will do, whether officially or unofficially, have a plan. Stick to that plan, because I've seen people just randomly doing one thing today and randomly another, and they don't realize what happens, but you got to measure it and then analyze it and fix it. If you're advertising, depends on what service you're doing. Women are the caretakers. So you want to advertise in women's magazines, for example, et cetera, et cetera. There's a lot of different things you can do along that time. This is a more detailed discussion, but at any given time, you want to make sure that you understand your return on investment if you're marketing. As an example, I was asked to consult for a surgeon's practice, and he was very happy that he spent $10,000 on advertising and he had $10,000 worth of revenue. What about all the other overhead and expenses and his own cost, etc.? So obviously, for every $1 that you spend, you need $3 or $5 or $10 worth of income coming in. So take-home points. This is a discussion we could have for a very, very long time. Is you want to learn to walk before you can run. You must find a mentor for yourself. I wouldn't recommend the day you leave training, the very first day you're going to go open your own. You got to make sure you want to be an entrepreneur, and remember, you're starting and managing a small business if that's what you want to do. If you're going to work within even a large academic center these days, each one of them is their own cost center, and you're still running a small business in that center if you are. And the basic principles of business apply in all of these things, just with a unique twist. So with that, I'll end on this. So thank you very much. Let me take some questions from all of you.
Dr. Chopra, thank you very, very much for your talk. We do have a couple questions that have come in. One of the first questions is, because building any practice takes time, what disease process did you focus on initially, if any, to get patients in the door? The first few months of your practice, how did you focus your efforts, and did you spend most of your time speaking with primary care docs or ads, or how about did you go about doing that?
Yes, so from my experience, the first thing I did was, excuse me one moment. Okay, thank you. If I understood your question correctly, it was when you first started, what is it that I focused on? Is that correct?
Yes, like what disease process do you focus on to get people in the door, or
Well,
patients
the
in the
first
door?
thing actually I would recommend is make sure that your start to finish cycle is good. So imagine that you've opened your practice and you are here in Chicago, and you say you'll take good care of PAD. And my mother has a wound on her leg, and I send her to you. What would I expect? I would expect for her to be, seen, information's collected, that you've explained everything to her, and then after that, the procedure is set up right. If she's diabetic, all the other things were taken care of. Then she had the procedure, her recovery was good, and then everything that had to happen happened well. There was a follow-up appointment, you saw her, and now her wound has healed and she has a pulse in her foot. What do you need to take care of that cycle? That's how you focus on this. And once you've conquered that process within your practice and you focus on that, then I went to the next step of making sure I talked to the primary care doc, who was very happy, and then I did lunch and learns with 5 other primary care docs. Each one of them talked to each other and they said, yeah, Chopra does a great job. And I actually started like that. So I wouldn't recommend putting out an ad at that time when you first start. I would recommend you go do a grand rounds or go to doctor's offices, introduce yourself, say hello, get a patient, and focus on taking good care of the patient, not just the procedure, but all aspects around it. Make sure you develop that right, then go on to putting ads and everything else. Did I answer your question? Did that make sense to you?
I think it did. I'll wait for that attendee to comment, but I think it did. And a follow-up question.
Go ahead. Follow-up question.
Oh, for fellows looking for their first job, how can you convince a radiology group to give time and resources towards practice building when it will directly take away from RVU generation?
Okay, so first thing is, if you want to be a Marine, I would not recommend you joining the local police department. You got to go join the Marine Corps. So if you want to be a IR practice and do high-level IR, do not join a practice and try to change their behavior. Instead, go pick a practice where they're doing what you want to do and do it well. I see this time and time again. IR fellows get out, they get enticed by making good money and a relatively easy lifestyle, and then they complain about why the diagnostic radiology group won't change their behavior. They won't. That's what they've built their last 30 years of practice on. They are not interested in now all of a sudden changing and taking more risk. And believe it or not, you can generate more RVU doing IR than just reading films if you do high-end IR. If you only just do PICC lines and biopsies, that is commodity work. You cannot make more money. But having said that, if you're already stuck in that situation, then you got to prove to them. But if you're just out of fellowship, your first few months, very hard. You're just out of fellowship. You just come. You don't even know what you're going to do yet. And now you're expecting them to take risk and do all of that stuff. Not happening. My advice in that situation is join a practice where that is not an argument you're going to have. Join the practice where they already have a setup and go be a good doctor and do more IR.
Got it. Dr. Chopra, along those lines, I know a lot of the attendees are actually interested in getting back into, academics when they're done, or kind of a private-demic, setting. For those who are interested in getting in academics, where the territory in terms of, PAD is kind of well established in the workflow of medical center. It goes to, interventional cardiology or vascular surgery. For institutions where the diagnostic radiologists may not really be supporting IRs coming into training, or the IRs may have lost it, how can we get some of that back in your expert, in your opinion? Do you feel it's feasible, or do you feel like it's kind of a battle that's already been won and lost in a lot of places? Or
yeah, it's very, very feasible. What you really have to do is make sure that, one, you're confident, and you got to win one patient at a time. You can't kind of expect somebody to just magically give you all that business just because you're an IR. What you really have to do in that environment is be friends with the cardiologists, be friends with the surgeons. If you have the skill set, do a small procedure. Make sure you have the credentials, make sure you have everything else, give a talk on it, make sure you've learned about how to take care of these patients well, and then find a gap that exists in that environment. They may not do pedal sticks well. They may not do, there may be a wound care center that's not happy. Find that need and then go in to solve that problem. That's how you'll get in. You know how I started? I was in a place where it was saturated. And I used to get consults for PICC lines, or just requests for PICC lines. I would never put a PICC line without a consult. I would go see the patient. And when I saw the patient, I saw that it was for a wound and severe PAD. And the patient had been told that they needed an amputation. And I convinced the primary care doc that I could do something better for the patient. One of them said, all right, go do it. I sent that patient back up to the floor with a pulse in their foot. That primary doc flooded my practice with PAD patients. So that's how I would recommend. It doesn't matter which center you are in. You find a need that exists and you fulfill it, you're golden.
Got it. Dr. Chopra, another follow-up question we have from the audience is, an attendee knows of some individuals who don't even have bachelor's degrees who invested in imaging centers. Do you think it's ever too early to start out as an entrepreneur, even if it's not within radiology?
Oh, entrepreneurship has got nothing to do with medicine. Entrepreneurship, and the answer is actually yes. And entrepreneurship is about saying, I see a need somewhere, I'm going to invest $1, and I'm going to solve this better than anybody else, and I'm going to make $10. That's what entrepreneurship is. If you're a physician and want to be a physician entrepreneur in the line of physician practice, you'll find a need and invest in something. So it's never too late. You don't have to have any degree. I've seen guys, I know of a person who did not even have a high school degree, was a brilliant entrepreneur, just naturally fantastic. He understood the principles and he made millions.
Got it. Along the same lines, in terms of your background and what you would recommend for those of us who are wanting to be more aggressive in kind of establishing our own practices going forward, do you have a formal business background, or how do you recommend we kind of go about getting more exposure to this?
Well, the first thing is, wherever you are, read some business books, not just medical textbooks. And you know what? Your practice is no different than a restaurant that's being run. And there are a lot of books, a lot of material out there. I used to read Inc. magazine, Howard Business Review. I read, all of Jack Welch's books. One day at a time, one thing at a time. Every practical problem that I saw, I said, okay, how can I make this better? Watch CNBC, learn the Costco model, the Walmart model, watch and learn all this stuff. It's life. And that's the way to do it. And then apply best practices within your medical practice. You can't go wrong.
Got it. In terms of expanding, and maintaining a practice, within that, what are some ways that you've worked with your staff in private practice to kind of develop and work in terms of your branding, but also in terms of your greeting and kind of making sure that everyone's on the same page within that. A lot of us who work in academic medical centers see a lot of people who are disaffected, who don't really care. They're not really passionate about customer service, and I'm sure it's not just in the academics; it's also in private, in community hospitals. What have you found to be effective in combating that? Because these people are your front line and are interacting with your patients.
So I'm going to make the assumption that you are the leader of that team.
Okay. Yes, if you are the leader of a team,
Leader of that
in
team.
that situation.
Tell you what, I tell you, I became the chairman of radiology IR at Rush before I became with the whole department. And if I saw somebody treat a patient poorly, I would counsel them, coach them. If they were not meant to do that, then I'd make sure their job was changed. When I became chairman, I made sure I went first to the Ritz-Carlton for customer service training myself. Then I sent all the front desk people for that. But bottom line is you want good, nice people, intelligent people. It doesn't have to be very expensive. They don't need a sophisticated PhD or a college degree to be able to be taught what they do. And you need to find people with passion and their hearts into it. And that's really, you have to be willing to make the change. One of the first things you need in leadership is courage. And if your vision is, and you look at a football team, look at the NFL today, look at basketball, in any of these organizations, professionally, you need the courage to set the trend of what you want to do. So if you're a front desk person, you are the leader, and you will be the role model. So I assume you're already treating patients well. And they need to look at you and say, okay, Dr. Chopra talks to the patient well. You don't give them the opportunity to repeat that mistake more than 3 times, assuming then we counsel them. So 3 strikes, they're out. I'll get somebody new, and I've done it.
Got it. Kind of switching gears in terms of customer service and going over to contracts. How strong are exclusivity contracts, within hospitals? Is it increasingly common for IRs to practice as independent physicians at hospitals that already have a DR and possibly an IR group?
It's growing because if the hospital has a need. So what I did was there were hospitals that had DR and their IR did not exist. So I was the IR. I went in and I offered good services. I made sure the hospital made money. I give good customer service. I've been doing it for 12, 13 years now in hospitals where they're existing DR but no IR. I even have, one of the hospitals where I am has a large academic center practice with, they have like 6 or 7 IRs. I do more volume than all of them combined. Why? Because patients come to me. Why do patients come to me? Because I work very hard to make sure I meet their needs, I give them good customer service, and the hospital makes a ton of money off my work.
Yeah. Have you found the politics of that within the cath lab or the interventional suite to be challenging in terms of getting cases posted or scheduled or what have you? Whether there's politics from administration if they want their hospital employee to do it, if you're a private physician. I mean, have you run into issues with that or no?
Yeah, you do, but you got to deal with it. So because I bring so much volume, guess who gets priority? I do. But if I'm not doing a good job, then I make sure I treat the cath lab staff well. But there are enough problems. There was one director who's always a problem. He's always creating issues. You got to deal with it. But believe it or not, with time, you will turn them around. If you have the right principles, you do the right, apply the right strategy of doing good quality work, they will admire your work, and soon they will fall in line. Then they say, you know what, Dr. Buck who's coming in, he's got all these patients, we're going to give him priority. And you just have to look at it. So will you face the challenges? Yes. Will there be politics? Yes. But the old days are gone where one IR department just controlled it and they blocked you and all that stuff. Hospitals don't have time for that. Hospitals are working on 1% and 2% margin. If you're doing good and bringing in patients and making money, they will happily embrace you. And here's a logic that I've followed. If they don't want you there, don't go there. Find a place where they'll want you, do good stuff, patients will follow you, you are the Pied Piper. Life is very good.
Got it. Dr. Chopra, one of the other questions we have in terms of training is, do you envision that interventional and diagnostic radiology will be separating more and more over time as the new IR residency is unveiled?
Yeah, I think that'll happen for those people who want to do only IR. As an example, do we realize that initially when medicine was practiced, one doc did everything. He did surgeries, he gave the medicine. When, he would put the medicine together, he would compound it. Then as it got more sophisticated, medicine and surgery broke apart. Surgeons used to also do gynecological stuff. Then that broke apart. Then when the X-ray beam was recognized, radiologists became more kind of core. Image-guided surgery, I think it'll come from different ways, and diagnostic radiologists who don't want to do touch patients and be surgeons or be doctors will separate. I think it's a logical, but it does not mean that other people will not study imaging. I think everybody will study imaging. It'll become the basics.
Mm-hmm.
But that will happen unless radiology does something different about it. But radiology wants to do imaging. I mean, and that's where I think it'll land up, and IR wants to be image-guided surgery, and that's what will happen.
Great. Do you have any tips for, another question we have is, even amongst the first-year residents, we have a lot of ideas of how we can make IR procedures more efficient, including, ultrasound instead of CT. Do you have any tips for, in terms of, changing, quality improvement or practice improvement within a hospital to navigate the politics within that? Even if you're starting out and your volume is still growing, it's you're not the high volume person at a facility or institution. How you could go about doing that?
So if I understood the question correctly, if you are in a place and you have some good work and good ideas, is that correct?
Right. If you wanted to change kind of some of the protocols or the ways about how procedures are done, or at least to kind of implement that more broadly within your institution, and you're starting out in practice or still in training, how would you recommend going about doing that?
One of the things to realize these days is we are in a place of evidence-based medicine. Nothing succeeds like success. So before you start changing the world around you, show that you can do it better, and make sure you have documentation and support around it. If you are really going out of, so let's take an example that, they are putting central lines blindly into subclavians, and they're getting pneumothoraces, and they're in bad shape. You can then bring papers in, show them that a ultrasound-guided jugular stick has low complication rates, be a leader, build that program, introduce those protocols, and solve the problem. There are committees designed around it. JACO is there. Talk to the people. Similarly with infections that occur in the hospital. One of the things specific to PAD, if you're starting in practice, look at the amputation rate in your hospital and see how many of those patients had an angiogram before that, and how many of them had some revascularization done. There's enough papers out there that show, and enough evidence that show, that if you do revascularization, the amputation rate drops, morbidity drops, mortality drops, and cost drops. With that in mind, actually show it with practice and bring it to a committee. There are quality improvement committees. There are other committees within the hospital, and you'll have to take some leadership role, but that's how you do it.
Yeah. Dr. Chopra, I know we're close to time here, but we just have one or two more final questions. What are the traits that, I'm sorry?
I said as many questions, no worries.
Okay. What traits are most important that you consider when hiring an IR attending for your practice?
Absolutely. The first thing is I want a nice person who cares about another human being, and then has the willingness to learn and solve other people's problems. So there may be somebody who's just exceptional in his quality of work, as in skills, but is an asshole. He's done. I don't hire him. So the first bottom line trait is that you're a kind, caring person who actually cares about patients and wants to solve other people's problems. The second thing that I look for is they are team players. And they are leaders and they are followers. Either you lead, you follow, or get out of the way. If there's somebody who's a leader, they lead automatically. And they don't lead by demanding other people follow them. They just show people the way and people follow. So I look for people who are nice, kind, courageous, and team players. Those are the first few things that are core. I've had some guys with brilliant scores, all kinds of other publications. They treat people poorly, done. You're out of the practice. You won't survive. They treat other doctors poorly. They treat staff poorly. And you know how I judge them? I've hired over 100 physicians in my career. I take them out for a dinner. And I watch after a couple of drinks how they treat staff and how they treat other people. And if they treat them poorly, I know they will not treat another patient well. And if they are leaders, you will find out in no time. If there's kindness, it will show up. If you're a golfer, take them out to golf. You'll find out in 4 hours what they are like. Get them a couple more drinks and you'll find out even more. But the point I'm trying to make is if you have a good person at heart who can do a good job, the sky is the limit. And that's what I look for. And I'm speaking to your heart, so I don't, these are not magical answers, but this is just how I feel.